So moving more inferiorly now, we're going to be covering the brainstem, and there are three parts to the brainstem. As you can see, going from superior to inferior, there's the midbrain, there's the pons, and then most inferior before we get to the spinal cord is the medulla oblongata. Now, a lot of times folks will abbreviate the medulla oblongata and just say medulla, which is totally fine, totally acceptable. Just make sure you don't confuse that with the cerebral medulla. Okay, that's got to be something different. That white matter here in the cerebrum is different than the medulla down here, very different functions. So you'll hear me abbreviated as well, but just know that the medulla oblongata is different. So let's talk about these three different parts of the brainstem. With the midbrain, we're going to have several different areas. We have things such as the red nucleus and the substantia nigra. That's just a little advanced. That's getting into very detailed neuroanatomy. So big things we want you to know here is it's an area for ascending and descending information. Ascending information is going to be sensory information, right? Stuff coming from the body up into the brain, specifically to the thalamus, right? All that sensory information goes to the thalamus, and then the thalamus routes it to its final destination. And then descending information is going to be motor, right? It's going from the brain down to the body to tell us to do something, digest your food, wiggle your fingers, whatever. And then we have the corpora quadrigemina, that huge two weird words that I mentioned earlier. We're going to dive into a little bit more of that on the next slide. The pons is basically, if you translate it from the Latin language, it actually means bridge. And basically it's the same thing. We're going to have sensory going down, we're going to have motor going up, but we're also going to have things going to the cerebellum and the frontal lobe too. So what you get with my awesome drawing right there is this crazy huge four-way intersection. You got things going north and south and east and west all at the same time, and therefore the pons is a very fitting name, bridge, pons, right? And it's also going to assist with breathing. It helps regulate breathing, but what you'll see in just a second with the medulla oblongata is the medulla is what's really in charge of your breathing, and the pons just kind of gives feedback and kind of just keeps things normalized. So the medulla oblongata, and you can argue with me and debate with me if you want, but I would say this is the most important part of the human body, right? You can say, oh no, the heart is, or oh no, the liver is, or oh no, the pancreas, or no, the cerebrum is. You have to have a frontal lobe. I don't know. If I had to choose one thing, I would say the medulla oblongata, because take a look at what it does. It controls the centers, or remember, centers are also nuclei. So all of those cell bodies and dendrites are located, or that they're just gray matter in the central nervous system. And these centers or nuclei control your heart rate. They control your blood pressure. They control your breathing, your swallowing, pretty much everything. So yeah, if your heart is the most important organ, what's controlling the heart? Well, this is the medulla oblongata. If your lungs are the most important organ, that's a pretty good answer. I would nod my head along with you. But what's controlling the lungs? The medulla oblongata. So very, very important part of the entire human body here. So let's move on to the next few slides. I'll show you pictures of these in just a little bit more detail, or at least zoomed in, and we'll talk more about the specifics. So with the midbrain, we have all sorts of different structures, substantia nigra, red nucleus. We have things called peduncles. Main thing we want you to know is the corpora quadrigemina. So the corpora, that means corpse or body, and then quadrigemina referring to four, it actually translates into quadruplets. So what you have is just four bodies, or four areas or nuclei. So let me draw over to the right. You'll see four circle areas, and in each of these circles we have clumps and clumps of cell bodies and dendrites. And we have two on the left and two on the right, and we have two above one another and two below one another. So we call these things colliculi. The singular form is a colliculus. So on the left side of our brain, we have a left superior colliculus and a left inferior colliculus. On the right side of our brain, we have a right superior colliculus and a right inferior colliculus. And when you put all four of these structures together, they make up this big unit called the corpora quadrigemina. So you can see what they're kind of associated with at the bottom of your notes. You can see the superior colliculi are dealing with some type of visual center, and the inferior is dealing with some type of auditory sensation. Great. What specifically do these things do? Specifically, the superior and the inferior colliculi are involved with tracking. What do I mean by that? Well, let's say you're looking outside your window while you're listening to this video because this video is boring. So you're trying to get distracted by anything other than this video. So you're looking outside and you see a dog running around, right? And then all of a sudden that dog grabs your attention. Your eyes move, your head moves, maybe your entire body moves towards looking at that dog. Or you're sitting in class and you see a car go by on the road and, oh, I really like that car, and your head moves along with that car. What causes your body to see something moving and then move your head and maybe possibly the rest of your body with that is the superior colliculus, or still the superior colliculi, excuse me. Any type of hunting activity, if you're tracking a bird, or you're shooting skeet, or if you're trying to even just catch a ball, right? If a ball's in the air and you have to follow the ball with your eyes, the superior colliculi is allowing you to track that ball so you can either catch it or hit it or whatever sport you're playing, kick it. The inferior colliculi are essentially doing the same thing, but this has to do not with seeing, but with auditory stimuli. So if you're in your room watching this video and you hear some scratching or some weird noises on the roof, well, how do you know it's on the roof? How does your brain know it's coming above you on the ceiling and not below you or not to the left or right of you? Well, that's the inferior colliculi. The inferior colliculi tells you where the stimulus is coming from. Where are those sound waves coming from? Are they in front of you, behind you? Say that somebody dropped a book, or somebody's cell phone's ringing behind you in class. What makes you turn around to look at that person with the cell phone is the inferior colliculi. It tells you, hey, that ringing noise is coming from behind you. So that's what these colliculi, or the quadrigemina, do for you. Pretty cool. Moving down to the PONS. The PONS, as I mentioned, is a bridge, and really that's kind of it. I mean, there are some cool things with breathing. We'll talk about that. But really, it's just a big highway. We got stuff coming north. We got stuff coming south. We got stuff going over here to the cerebellum, which we're going to talk about in just a moment. And the cerebellum is also sending messages to the frontal lobe area. So big 4-lane traffic jam highway. As I mentioned, it's going to help with breathing, also going to help with some motor movements, because all of those action potentials that go from that frontal lobe, that precentral gyrus area, that primary motor cortex, guess what? It's got to go through the PONS to get down to the spinal cord. And then at the very end of this chapter, we're going to introduce cranial nerves. And there's 12 pairs of cranial nerves that branch from different structures in your brain and brainstem. And 4 out of those 12 pairs come right here from the PONS. And they help with all sorts of cool things, such as eye movement and taste and hearing and balance and smiling and all sorts of neat things that we're going to talk about. So things that we take for granted a lot of times every day, the PONS, in a way, controls that. And then last but not least, in the brainstem, the medulla oblongata. And very important part with the medulla oblongata. I'm going to spend some time on this slide. Number 1 bullet point, as you can see, the decussation of motor tracts. All right, what in the world does that mean? All that means, a decussation is an X. It's an intersection. That's all it is. So, check it out. All of that, recall back to the cerebral medulla, right? What's the difference between the cerebral cortex and the cerebral medulla? One's gray matter, one's white matter for the most part. So the cerebral medulla was that white matter, that myelinated axon area. So what happens is, what we're looking at here is, this is your right brain, and this is your left brain. All of those axons in this area as they're going down the brainstem and they go out to the spinal cord, go out to your arms and your legs and your torso and all your structures, your organs, they start making their way down like this, and at the medulla oblongata, they cross with all of the axons from the left side. So you get this big X of these motor tracts. Now remember what a tract is. Go back in your notes. A tract is the proper term for bundles and bundles of white matter, bundles and bundles of axons in the central nervous system. And we're still in the central nervous system, brain, brainstem, spinal cord, right? So remember, a nerve was bundles of axons or white matter in the PNS. CNS, they're called tracts. So, with this knowledge, now you understand why the right side of your brain controls the left side of your body. So everybody wave their left hand, start making a fist or wiggling their left fingers. What part of your frontal lobe is actually making that happen? Is it your left hemisphere frontal lobe or your right hemisphere frontal lobe? And if you're waving your hand or wiggling your fingers on your left hand, it's your right brain causing that to happen. If you wiggle your toes on your right foot, your left brain is what's doing that. All right, so let's bring this all together and review this. Remember, we were talking about unfortunate head trauma, right? Any type of brain lesion or brain trauma or a stroke. Remember, if somebody was to have a stroke where something gets blocked, you throw a clot and the clot gets stuck in an artery in the brain and it kills several brain cells, what's going to happen is that's going to affect a good portion of your body depending on the severity of the stroke. So, if somebody was to have a right brain stroke, what side of their body could be temporarily or permanently paralyzed? So if cells in the right side of the brain die, the left side of the body is what's affected. The right side will be totally fine. You can move your right arm and right leg, no problem. The problem is the left side is going to be significantly handicapped or dysfunctional. What about the left side? If we have a left brain stroke, what would happen? What are some of our symptoms? Well, the right side of the body is going to be affected. But remember, those speech and language centers are also on the left side. That Broca's area and Wernicke's area is also on the left. So not only would we get deficit or really bad paralysis on the right side, but we'd also have speech issues and language comprehension issues potentially, just depending on what part of the brain was affected by that trauma or that stroke. So the medulla oblongata is where this decussation or this crossing occurs. Second bullet point, moving on, as you can see, the sensory tracts from the spinal cord enter here. So you look at this picture on the left, you can see the brain and the brain stem. So the medulla oblongata is in red, the spinal cord is just right below it. So the foramen magnum, depending on who you talk to, people argue about this, but the foramen magnum is somewhere in this area, that big hole in the bottom of your head. And basically the brainstem and the spinal cord connect somewhere above, below, or right at that foramen magnum. With the PONS, recall that it was 4 pairs of cranial nerves are going to branch from here. We're going to also have 4 pairs of cranial nerves branching from the medulla oblongata. And these are also going to do really cool things. They're going to help control heart rate and breathing. They're going to help you with swallowing and taste. They're going to help you with neck and shoulder movement and moving your tongue. So all sorts of cool things that we'll discuss in just a little bit. And once again, to summarize all this, we have very important nuclei, very important cell bodies and dendrites that send axons down to certain parts of our body, and they control your heart rate, your breathing, your blood pressure, your swallowing, even something such as vomiting is controlled by the medulla oblongata. So very, very vital, very important. So now that we've covered the 3 main areas of the brainstem, the midbrain, the pons, and the medulla oblongata, now we can introduce the reticular formation. And the reticular formation is really, really cool. As you can read, it's a network or a mixture of gray and white matter all throughout the brainstem. So it spans from the midbrain down to the medulla oblongata, or from the medulla oblongata up to the midbrain. And this helps with a lot of cool things. As you can see, there are some reflexes that we're going to introduce. More so next chapter, we'll talk about reflexes. But two main things what the reticular formation does for us. They're really, really cool. Number one is this is the main area of your body that keeps you awake. Now, we mentioned the thalamus plays a little role. Yeah, the hypothalamus plays a little role as well. But this is the only reason why you are conscious right now listening to this video. When you actually fall asleep, when your sleep cycle starts changing, you go from stage 1 to stage 2 and you go deeper and deeper in your sleep cycle, it's the reticular formation shutting things down. And then therefore telling the brain, hey, let's calm it down, shut it down, and then you can go into the different stage 4 and REM and start dreaming and all those other things. So that's one thing the reticular formation does. The other thing that the reticular formation does is it filters out 99% of our sensory stimuli. Now, recall with me, what is the major airport or the major relay station or the hub, the capital of moving all sensory stimuli to their proper destination? And your answer should be the thalamus. And you can see in this picture, that's great. This is actually a really great illustration. Look at the thalamus. I'll highlight it in purple. Here's the thalamus. Well, let's do a different color. Let's do red. Here's the thalamus in red. And notice, all these arrows are going to the different parts of the cerebrum from the thalamus. That's great. But take a look at what I just said, and what I'm writing is the reticular formation filters 99% of sensory stimuli. And that's just crazy to think about. Like, how nuts is that? As you hear me, you are focusing on the words coming out of my mouth, but that's really it, hopefully. Now, yes, we can get sidetracked. That's okay. But think about all the things that are happening to you right now. I'm standing in my kitchen, believe it or not, recording this video, and there are a million things going on around me. There's this huge bumblebee thing that just smacked right into the window. I'm looking at some birds outside. My throat's a little raspy. I actually just paused the video to cough a little bit. My refrigerator is making some weird humming noise. My wife's going to be opening the garage door any minute, so that's going to make a loud noise in the recording. My neck's a little itchy because I haven't shaved in a while. My socks are kind of tight. I'm going to take off my socks and let my feet be free. My phone just pinged with a text message. I'm getting kind of hungry, so maybe I should pause the video and make something to eat. There's a million things going on right now. But with the help of the reticular formation, we can filter all that stuff out, so I'm not distracted by that bumblebee or the weird humming noise or what I'm going to make for dinner later tonight. I'm focusing on telling you what the reticular formation does. So it helps you focus is what this thing does. So you're not totally distracted and you see a squirrel and totally lose train of thought, right? So with the knowledge of the reticular formation keeping you awake and filtering out 99% of your sensory stimuli, what are some kind of drugs that can affect the reticular formation? And based on all the crazy things I just said, with all the weird noises and the sights and the sounds and the smells, right? Some of us may be able to relate. I've never been tested for ADD, ADHD, but I do get sidetracked from time to time. I wouldn't be totally shocked if I have a little bit of it. I don't know. So, folks with ADD, ADHD, you may have a hard time staying focused. You might get distracted. You might have too much stimuli going on where things do sidetrack you and get you off, on a tangent sometimes. That's okay. Let's think about the medication that some folks with ADD or ADHD take. Now there's different types and different brands and generic names. You can take an Adderall or Ritalin, and I'm sure there's other ones. Those are the main ones. But what does Adderall and Ritalin do? It helps you stay super, super focused, right? If we were to say that I'm not, and I've never taken this drug, but say that I don't have ADD, ADHD. If I was to pop in 2 Adderall to, I don't know, focus on my anatomy test, don't do that. But make sure you have a prescription because it can be weird. I'm going to explain why in a second. But say that you were studying for some test and you wanted to stay up all night or something like that and really, really focus, that pill would help you do that. It would help the reticular formation kind of go into hyperdrive. And not only would you be focused and studying your stuff, but you'd also be able to do the laundry, wash the dishes, walk the dog again, and study some more. You'd be extremely focused. Now, once again, I'm not advocating the use of this drug recreationally. Don't do that, because when you've seen it in the movies or the TV shows, what happens to somebody who takes this drug and doesn't need it is they are wired. They cannot go to sleep. You hear those weird cases online or on the radio or something where this person hasn't slept in 3 days and now their liver's shutting down. Yeah, that's the kind of stuff that can happen. Because if you are stimulating the reticular formation with a synthetic drug, yes, you're super focused, but what's the other part of the reticular formation's function? It keeps you awake. You can't go to sleep. So, I mean, how awful would that be? You've stayed up for a day and a half, 2 days in a row, and you try to go to sleep and you can't sleep. Bad, not good, right? We don't want that. Another example of a condition that can possibly be affected by or is affected by the reticular formation is anybody on the autistic or autism spectrum, right? And there's a lot of different severities. But what is the main, or one of the main symptoms of somebody who has an autistic disorder? It's they don't handle sensory stimuli very well. A lot of them are very, very sensitive to touch. If you touch them and they're not used to you, it can actually be somewhat painful to them. Loud noises really wig them out. They can't stand being in a new place with loud noises or weird smells. And it's not because they're extra sensitive. Well, I mean, it is, but it's not because they can't cope with it or they can't handle it. It's because their sensory stimuli is not being filtered. So picture you talking and then being distracted by the bumblebee and the weird humming noise and the light and the itchy neck and the weird thing on your ear and the watch on your wrist. And all these things are constantly telling your brain, hey, be aware of this, be aware of this. Something's touching you, some light's happening, this noise, blah, blah, blah. All this is happening at once. You'd freak out too. So what happens with folks with autism is, unfortunately, their reticular formation doesn't work at 99%. I don't know what that number is. Maybe it's 90, maybe it's 80, maybe it's 92. I don't know. But if you don't have that filtering working for you, you can be very, very overwhelmed and extremely sensitive to any type of sensory stimuli, unfortunately. Now, the drug wouldn't really work, though. You don't want to mix the ADD, ADHD drugs with autism because, once again, it's a different function. It's the awake center that can really be messed up with that, so you want to be careful of that. But just to kind of give you an idea of what the reticular formation does. Pretty cool, huh? And the last thing we're going to talk about regarding the brainstem are brainstem reflexes. And a reflex is basically just a predictable response to a stimulus. So to give you an example, if something goes wrong with your heart rate, for example, if your heart rate goes up and you're not exercising, your body needs to do something to bring it back down. So the reflex is to lower it to normal rate, right? If we stand up too quickly and our blood pressure goes down, which happens sometimes, especially as you get older, stand up too quickly, and you get a little lightheaded, kind of dizzy, fainted-like symptoms, you have a mechanism in your autonomic nervous system to fix this really quickly to bring your blood pressure back up. That's a reflex. Just fixes things. Most of this is going to happen through negative feedback mechanisms. So we have two types of reflexes or groups of reflex centers in the brainstem. We have vital reflex centers and then we have non-vital reflex centers. So the vital reflex centers are vital to life. They are essential. You need them every single second that you are living. As soon as this stops happening, you are potentially dead, unfortunately. So where these occur, where these nuclei are, is only in the medulla oblongata. Now you're going to have reflex centers in the pons and the midbrain, but those are non-vital. The ones that keep you alive, once again, the medulla oblongata keeping you alive, is found here, the vital reflexes. So we have the respiratory center, which controls your breathing. We have the cardiac control centers. We have one that makes your heart rate go faster. We have one that makes your heart rate go slower. And we'll learn about that next semester. And then we have the vasomotor center. And the vasomotor center is referring to our blood pressure. So we need to make sure our blood pressure is not too high or too low. And all of these are found, once again, in the medulla oblongata. Next, we have the non-vital reflex centers, and these are basically, they're still important, don't get me wrong. I mean, take a look at some of the, swallowing's pretty important. I think you kind of need that to live, but it's not a life or death thing every second, right? I need oxygen coming into my body every few seconds. I need my heart beating every second or 2 seconds, right? That's vital. Swallowing, I can go I don't know, I can go a certain amount of time without swallowing. But eventually it does become essential to an extent. So where the non-vital reflex centers are found is everywhere throughout the brainstem. They're kind of just spanned, just like the reticular formation. The reticular formation spans the entire brainstem, so do the non-vital reflex centers. So what are these? Vomiting, coughing, hiccuping, sneezing, even yawning, all are found in these areas throughout the entire brainstem. This next slide is basically just a recap or a review. We've already covered this. Remember that the tracts are white matter found in the central nervous system. It's just bundles and bundles of axons. And basically with the brainstem, and the spinal cord, we're getting this kind of 2-lane highway. So let me draw the cerebrum up here. I'll just put brain, because we had the cerebrum, the diencephalon, and all those structures that we talked about. And then here is your brain stem in purple. And then your spinal cord will be in red. And remember, from the brain and the brainstem and the spinal cord, we have all these nerves that just go every direction. And they go out to your torso and your arms and your legs and your eyes and your nose and your tongue and all those different weird things in your body. And basically, they serve as a 2-lane highway, the brainstem and the spinal cord and the brain. So we have messages from the brain, those efferent messages leaving the brain. Let's say we're going to wiggle our toe. So the message goes down the brain, down the brainstem, down the spinal cord, and eventually it's going to go out our lower body down to our toe. And then I did this morning, stubbed my toe so hard, y'all, on just a side where a corner is in my house. And anyway, very significant pain signals and some words said. So as those pain messages went from my toe, they had to go up my spinal cord, up the brainstem, up to the brain, right? So we have messages, and that would be an afferent message, a sensory message. So messages going down, messages coming up, 2-lane highway with this white matter, these tracts. Now, very important, just to make sure I'm not confusing anybody, once we leave the spinal cord, so this area in orange right here, as soon as we leave that spinal cord or the brainstem, this area too, brainstem doesn't matter, anything in red, that's not spinal cord, all of this stuff, that is not a tract. Remember, that's going to be PNS, or peripheral nervous system, and the word for axons in the peripheral nervous system are nerves. So nerves are all the things circled in orange, and then everything that's not circled in orange is going to be tracts when we're talking about the myelinated axons. Okay, so we have talked about the cerebrum, we've talked about the diencephalon, we talked about the brainstem. The last part of the brain that we need to discuss before moving down to the spinal cord is the cerebellum. So to give you an idea of where the cerebellum is located, you can see the picture on the, well, both pictures, but the picture on the bottom kind of gives you a cool clue. Here's your frontal lobe. Here's your corpus callosum, the big C thing. This would be your thalamus area. Here's your occipital lobe. So the highlighted in purple, that's the cerebellum. So it's just inferior to the occipital lobe, and it's just posterior to the brainstem. So here you can see it circled in red, that's the cerebellum. And then here is our midbrain, here's our pons, and here is our medulla oblongata. So it's posterior to the midbrain, and posterior to the brainstem, all the brainstem, and inferior to the occipital lobe. Now here's the cool part. Most of the structures are the exact same thing as the cerebrum, so we don't really have to learn all this new crazy vocabulary. We have a cortex, and we kind of have this medulla area, and it's going to be the same thing. The cortex is going to be mainly gray matter, and the inside part is going to be mainly white matter. And we have all of those convolution things, those bumps, right? Or those worm-looking things, we call them gyri or gyri. It's the exact same thing in the cerebellum. And then the little indentations are called sulci. It's the exact same thing in the cerebellum. They're just going to be a lot smaller, as you can see in your notes here. The gyri and the sulci are a lot bigger in your cerebrum, so kind of harder to see on the cerebellum, but they are there. So now that we've got the anatomy down, we know where the cerebellum is located. Let's talk about what it does. So the cerebellum is basically the area that helps us with smooth and coordinated and kind of fluent body movements. So as you can see in bold, there are three big things that you need to know with the cerebellum, and all of them involve skeletal muscles. So number one is skilled movements. And skilled movements, I mean, just think about any athletic movement. Think about typing a text on your phone or your handwriting, something like that. Those muscles are designed to move, right? But for the most part, those motor units really they're just sending electricity to the muscle, and the muscle contracts. And remember, although the neuromuscular junction and all that was kind of complicated, if you think down just to the sarcomere, all that's happening with the sarcomere is myosin actin are overlapping, and those two Z discs are coming closer together. So when a muscle contracts, the ends come closer together from the sarcomere perspective, and that's it. What makes them fluent, what makes you able to walk as your left arm goes forward, your right leg goes forward, and vice versa, is the cerebellum. It makes things nice and fluent and smooth. Another thing with the cerebellum is equilibrium, your balance. So it works with the inner ear. We're going to talk all about the inner ear next chapter, and the eyeballs and everything. But working with your inner ear and your balance equilibrium centers is the cerebellum, to make sure that you're not falling over. Basically, your brain knows where the level horizon is at all times. So if you do stand on one leg, you're not going to fall over or tip over, hopefully, because your brain can make those adjustments. The cerebellum tells all the muscles on that leg you're standing on, hey, we're leaning, we got to move, we got to contract this way to make sure you don't fall over. And then another cool thing with the cerebellum is your postural muscles, all those tonic contractions, right, that we take for granted, all those muscles in your abdominal region, your lower back, your core, that are helping you stand up or sit up and basically just not fall over every single time you do something. Cerebellum is involved with that. So, a couple more things I want to add here. The transverse fissure, I kind of skipped. The transverse fissure is just that area. Remember, a fissure is just a really large sulcus, so it's a large groove. And all that is the groove that separates the cerebrum from the cerebellum. So specifically, it's the thing that separates the occipital lobe from the cerebellum. So you got the occipital lobe up here, and then you got this space, and then you have I'll just put CB for cerebellum down here. So that space between the occipital lobes and the cerebellar hemispheres is called the transverse fissure, kind of goes across. And to kind of bring my point to this with the cerebellum, two more things I want to add. One, alcohol affects this very immensely. And not that any of you know what I'm talking about, but alcohol tends to affect your frontal lobe and your cerebellum. And let's think about it. When we watch the movies or the comedies or whatever, and people get plastered drunk, what are their symptoms? Well, one, they make some silly choices, right? They make some silly decisions because that frontal lobe, that prefrontal cortex that helps you make, your intellectual, logical decision making, that goes out the window, right? I'm an awesome dancer if I had 9 beers in me, right? You've heard that before. It just kind of, your inhibitions kind of change. But also, your cerebellum is affected by alcohol. So if somebody is very drunk, what's happening to their skilled movements and their balance and their posture? Well, they go away. So when somebody gets pulled over and the state trooper or the cop says, hey, walk in a straight line for me, or hey, close your eyes and touch your fingers to your nose, why do they make you do that? They're testing for cerebellar integrity. If your cerebellum is off, you either were born that way, you had a severe injury, or you're drunk. And that's kind of it. So before you finish this video, please close your eyes and touch your fingers to your nose. Make sure that you can do that. If you cannot do that, let me know, because you probably need to go see a neurologist. That's not good. Not good, not good. And the second thing I want to bring up with the cerebellum is we're still learning about this. The cerebellum is really, really cool. I've heard in the past where in some neat cases, if the cerebrum is damaged, like parts of the temporal lobe or the frontal lobe's damaged, the cerebellum can actually take over some of those duties. They call it the mini brain. And even if the cerebellum is injured, they've showed that the cerebellum is also involved with thinking and language and emotion. So they're doing a lot of research with it. We still don't know everything that it does, but we do know that it's heavily involved with these 3 things: skilled, fluent movements, your balance, and your posture. So similar to the cerebrum, we have a left and right cerebral hemisphere. Same thing with the cerebellum. We have the left and right cerebellar hemisphere. And the thing that joins them together is not called a corpus callosum. In the cerebellum, it is different. It's called the vermis. And you should be able to note that in lab, the thing that connects these 2 things together. It's just basically the midline of the cerebellum. And last but not least with the cerebellum, as I mentioned before, we have a cortex on the outside and we have an inside with a lot of white matter. So the outside, as you can see, gray matter, a lot of cell bodies and dendrites there, non-myelinated. And on the outside, the cerebellum has this really cool, unique pattern. So remember, with the cerebral medulla, yes, all that white matter just kind of goes towards the midline, towards the middle area. But in the cerebellum, take a look, it kind of makes this cool, like, tree, branch, root looking structure. So what they call that is arbor vitae. And arbor vitae, as you can see, translates to tree of life. So it kind of just makes these real cool root branch extension looking structures. And that's the white matter of the cerebellum. So once again, these are the heavily myelinated axons. So arbor vitae is only found in the cerebellum. This is the only part of the central nervous system where you find this, with this tree branching appearance. Okay, so we have covered the brain and the brainstem. We are now moving inferiorly to the spinal cord. This will be our last section for the central nervous system. Now, the spinal cord is pretty straightforward. You don't want to rush through it to miss any of the important details, but for the most part, this first bullet point does a really great job at honing in on what the spinal cord actually is. It's a 2-lane highway. It's a 2-lane path. So messages are going down, and whenever we have a message going down, remember that's going to be a motor message, and we're also going to call this a descending tract. I'll just put a down arrow for now. But a motor tract and a descending tract is the exact same thing. And you can also call this an efferent tract or an efferent message. All the same thing. And then if you flip it, messages coming up the spinal cord to the brain is going to be a sensory message, also known as an afferent message, also known as an ascending tract going up. So when we actually learn how to name tracts next chapter, it'll be very, very straightforward. Major reflex center, we're going to have a lot of activity, neural activity going back and forth. Remember we had those interneurons that we talked about last chapter. So 1% of the body is made up of those afferent and efferent neurons, not the messages, but just the neurons by themselves. And then what connects them all are the 99%, the interneurons. And a lot of your interneurons are found right here in the spinal cord. Now the spinal cord extends from right where that foramen magnum medulla oblongata end all the way down to about T12. And I'm grateful that your book pointed this out because a lot of folks don't say this. It goes all the way down to around T12, L1, even L2, some books say. And that's where it ends. And after that, we still have neural tissue. As you can see, you still have central nervous system tissue going all the way down to the sacrum and even to the coccyx. But it's no longer spinal cord. It's called something called cauda equina. Cauda meaning tail and equina meaning horse. So it looks like a horse tail appearance. And basically it's just where all the tracts start to feather. And they just kind of look like a bunch of loose hairs down here. So the true spinal cord ends right around that low thoracic upper lumbar region. And of course we know what protects it is the spine, the vertebral column. So the spinal cord is housed inside of that vertebral foramen or the spinal foramen as we learned in lab. This slide has some phenomenal images of the spinal cord. What we're looking at specifically here is a transverse section or a transverse cut of the spinal cord, also known as a cross section. So to refresh you, what a transverse section is basically we're separating the body into a superior and inferior half. So we, for example, cut off the torso or cut off the head, and we're looking down into the spinal cord here. So let's look at this top picture first and focus on the different parts we need to know. So here would be the posterior part of this top picture, and this would be the anterior portion. And since we're looking down into somebody's spinal cord from an anterior to posterior view, this would still be the right side of the body, and this would still be the left side of the body. Okay, so remember that just like the brain, we have gray matter and white matter. The only difference here with the spinal cord is it's flip-flopped, and we're going to have a couple more detailed names is all. So let me take your attention to the bottom picture quickly. And same thing, this is going to be the posterior aspect. This is going to be the anterior aspect of this picture. The stuff in the middle that kind of looks purple-like, that is the gray matter. So I'm going to put a couple G's here for gray. And then same thing on the top picture, gray, gray, gray. Once again, what is gray matter when we're talking about the neuron, the functional cell, the nervous system? All it is a bunch of cell bodies and dendrites bunched up together. Everything else in the spinal cord cross-section here is white matter. So all this stuff that appears blue, I'm going to put a bunch of white W's here. That is all white matter. And now I'll put black W's up here for color contrast purposes. This is all white matter. Once again, white matter, bundles and bundles of myelinated axons. Okay. So in the spinal cord, we have names for this stuff. Let's first do the gray matter up top, where we have collections of cell bodies in this gray matter, where what we call them are horns. And you can kind of see where they would get that name from. We have these kind of end-looking structures here. And I guess, I don't know, I guess you can say they look like horns. A Viking hat right here, right? So let's name these horns, and they're very easy to name if you remember the alternative words for anterior and posterior. In chapter 1, we said that we won't come back to this until the nervous system. Well, here's the nervous system. So instead of using the word anterior, we often use the word ventral to describe spinal cord anatomy. And you can see in the picture, anterior is not wrong. You can see actually ventral's in parentheses, but just for clinical perspective and terminology, you'll hear ventral and dorsal more commonly used. So this area in the front of the spinal cord, the anterior portion of this gray matter, these are called the ventral horns. Once again, anterior is just fine, that's okay, but ventral is just more common, the ventral horns. Okay, if you go to the top side of the posterior side of this picture, you'll see that we have the dorsal horns. And as you can see, dorsal is the same thing as posterior. So we have dorsal horns on either side of the spinal cord. Okay, let's talk about the function of these two parts, these two sections, anterior and posterior, and then we'll bring it back and I'll show you the third horn. Remember the brain physiology. The frontal lobe does what? Is it motor or sensory? And hopefully we're saying motor, right? The frontal lobe is your motor centers. So the front part of your spine, of your brain, helps you with movement. Same thing with the spinal cord. Let me separate this in half real quick. If we were to separate this in half, the front part of the spinal cord helps with movement as well. This is motor function. So front part of the brain, motor function, front part of the spinal cord, motor function. What does the posterior part of the brain do with the parietal and the occipital lobe and part of the temporal lobe? It's all some sort of sensory, right? Touch, hearing, taste, seeing, all that stuff. Same thing with the spinal cord. These are your sensations. So the back side, your dorsal area, is for sensory function, and the front side is for motor function. All right, take a picture of that, take a mental image of that, because we're going to add on to that in just a little bit. Okay, so we have the gray matter. We've talked about the ventral horns in the front, dorsal horns in the back. We have one more horn that I want to discuss, and that's the lateral horn, and that's this kind of area right here, this tip. And as you can see, it's pretty close to the ventral horn. The lateral horn, because it's so close to the ventral horn, and you can see it really well here in the bottom picture too, this is also going to be involved with motor function. It's going to be a little different, but it's still involved with motor function. Alright, so that is the gray matter. That's just the cell bodies and dendrites. The cell bodies and dendrites have to be attached to axons, and the axons go everywhere. So the axons are out in the white matter. Let's talk about the names for the white matter now. So we have ventral, dorsal, and lateral horns for the gray. The white matter, they are called funiculi, or columns, are more commonly used now. So just in case you see this on a test or a book, funiculi, or funiculus is singular. But we're just going to call them columns for now. It's the same thing here. All of the stuff on the posterior side, we're going to call these the dorsal columns. So all of this area on the back side of the spinal cord, dorsal columns. All of this stuff on the front side, these are going to be called the anterior columns. And then what do you think the lateral stuff's going to be on the side? You guessed it, lateral columns. Okay, so columns are the white matter, horns are the gray matter. So here's how this is going to go down. It's pretty cool. The front side, the anterior side, is where we're going to be sending motor neurons out to the periphery. So what happens is you have a whole bunch of cell bodies and dendrites in your ventral horn. You can see the little purple circles that I'm drawing. And the axons go out to the white matter, and then they eventually leave the spinal cord. So I'll draw them over here too. Now, the message or the direction of this message is leaving the spinal cord. It's a motor message. So I'm going to draw a big arrow pointing away from the spinal cord. All right, this is going out to your arms and your legs. Now, what happens with the sensory? How is our brain made aware of something touching you? It has to, if something's touching your foot, it has to come up through the spinal cord, then to the thalamus, and then to the parietal lobe. So, if we have, same thing, I'm going to do this in red, maybe, red, there we go. If we have a bunch of cell bodies in the dorsal horn, they're going to also send axons out well, actually, the axons are actually coming in. I apologize. But these are those pseudo-unipolar neurons from our skin, for example, if something's touching us. And they're going to synapse with cell bodies in that dorsal horn. So I'll draw my little pseudo-unipolar neuron out here. And then we'll talk about you'll see a dorsal root ganglion. I'm not really covering that now. I'm missing a big piece of this equation, but I'm just drawing this so you have an idea. These messages are coming towards the spinal cord, afferently. So not only is it a two-lane highway from an up and down perspective, going to the brain and away from the brain, it's also a two-lane highway, or I guess you can say a four-lane highway in this picture, of stuff coming into the spinal cord and going out of the spinal cord. Now, check this out. What happens with a lot of these axons? With the nerves. What is a nerve? A nerve is a bundle of myelinated axons. All right, the white matter stuff. What happens is all of these axons fuse together. So look at the tips, or the most lateral part of the picture. I'll circle it in green for us, where the sensory and the motor fibers merge. The sensory and the motor fibers merge. This is what we call the spinal nerve, and almost every single one of them, 99% of them in your body, are mixed nerves. And what that means is it has a motor component and a sensory component. Don't believe me? Scratch your arm and move your arm at the same time. Are you moving your arm? Yes. Can you feel yourself scratching your arm? Yes. Because you have both motor capabilities and sensory capabilities in your arm, or whatever part of your body you're moving, we know that we have both afferent and efferent messages going on. We have both sensory and motor neurons in that area. Now, when we get to the cranial nerves at the end of the chapter, that's going to vary a little bit, but 99% of the nerves in your body are like this. They are actually mixed. They have both motor and sensory capability. Okay, one last thing we're going to cover, and then we will move on to the next slide, is if I clear all this out, in the very, very middle, well, actually, two more things. I lied. Let's cover the lateral horn real quick. The lateral horn is going to be involved with the autonomic nervous system. So as I mentioned with the ventral horn, this stuff's going to go out to your arms and your legs, that kind of thing, the limbs. So what's talking to our heart and our lungs and our stomach and our intestines? We have to have axons going there too, right, to tell us to digest our food or tell our heart to beat faster, that kind of thing. That would be the axons from the lateral horn. So there's only a certain part of the spinal cord, we'll talk more about that later on, only in your thoracic region that has a lateral horn. But the lateral horn is going to be more of our fight or flight or rest mode, our chill mode. It's going to be more of our involuntary organs, where all of your skeletal muscles are going to be more of the ventral horn. Again, we'll have a whole chapter on that at the very end of the semester. Just wanted to point it out so it's not new information when we get there. Last thing, if I clear all this information out, and you look at the very, very center of the spinal cord, you'll see a little hole. And in that hole is going to be a very important fluid called cerebrospinal fluid. And we're going to have cerebral spinal fluid on the outside of the spinal cord. We're also going to have it on the inside, and this is where it flows on the inside of the spinal cord, something called the central canal. Okay, we're going to get to cerebral spinal fluid in just a little bit too, but make sure you go back, review these, make sure you know the horns versus the columns, make sure you know which one's motor, which one's sensory, which one's white matter, which one's gray matter. All right, moving on. So once again, the spinal cord is a two-lane highway. We have information going up, or what we would call an ascending tract, or an ascending pathway, and that's all going to be sensory information. So whenever you see ascending, you should associate that with afferent or sensory, and then same thing with motor. Descending would be more of our motor pathways. Efferent. Okay, so one more thing we have to discuss is what happens when the spinal cord is damaged. So, what I want to cover first is severe damage, severing, and then I want to go into a little bit more specifics with what you'll see more in a clinical setting. So, let's talk about the word severing. What severing means is to completely separate. Right? If I have a branch on a tree and I sever that branch, I'm completely separating it from the tree. It is now two pieces, right? So if we were to sever the spinal cord, if we were to cut the entire thing at a point in the body, anywhere from that point down, from the severing down, is completely paralyzed because all motor function has been compromised, all that anterior horn and lateral horn has been compromised, and the dorsal horn and the dorsal columns have been compromised, so they will therefore be completely numb or completely unable to feel anything. So, for example, if we were to cut the spinal cord at the belly button, say that you're in a really, really bad car accident, just very, very traumatic motorcycle or some type of motor vehicle accident, and the spinal cord is actually cut in half at the belly button. What would happen is from the belly button down, you would be paralyzed and you would not have feeling in your legs and hip area. So when that happens, for example, at the belly button region, you can see in your notes spinal cord at the thoracic region, or it could be the lumbar region, but basically anywhere below kind of the heart, basically, that's going to paralyze and permanently numb the legs, both legs. So when we get numbing and paralysis of those two limbs, the left and right leg, we call that paraplegia. So if somebody's a paraplegic, that means that they cannot move their legs. Okay? Now let's take it a little more extreme. Let's take it more higher up or superior regarding the spinal cord. If we have some type of neck injury to where we broke our neck and the vertebrae that chipped off or fractured actually severed the spinal cord, then you would be paralyzed from the neck down. So yes, it would include the belly button down, but everything from the neck down. So if you were to do that at the neck region, the cervical region, you would be numb and paralyzed in the arms and the legs. So all four limbs would be affected, and therefore you would be considered a quadriplegic, quad. So therefore you would probably be in a bed the rest of your life, or a really, really high-tech wheelchair. Alright, so those are the extremes. That's the very depressing stuff, right? And that does happen, unfortunately. Folks do, you see this a lot in really bad car accidents, like I said, also football injuries, and really, really just bad sporting events. Okay, let's get to more common spinal cord injuries and see how this will interact with clinical symptoms. So let's draw our cross section of the spinal cord. Draw it right over here. And I'll draw my nice little weird butterfly looking thing. Remember, that's the horns, the gray matter, right? So I'll color all that in. So everything in green is the dorsal, the lateral, and the ventral horns. That's the gray matter, all the cell bodies and dendrites. And everything in white is the white matter, the axons. Okay, so let's picture with me a lumbar spine. Okay, upper lumbar, lower thoracic area. It can even be lower lumbar, even though it's not the exact same tissue. But let's say that we had an injury to where we blew a disc. We herniated one of those fibrocartilaginous discs, those symphysis joints. Okay, we lifted something too heavy and something ruptured. But when it ruptured, it fell on the vertebral level below it, and it only affected this area of the spinal cord, or this area of that nerve. So here would be the right side of my body, here would be the left. So we're talking about the lumbar region, so what symptoms would I feel? Would my arms be affected at all if we're talking lumbar, if we're talking lower back area? No, arms are fine. But what would be affected? Well, we know the right side's going to be affected with something, right? The left side is fine. Let me draw a line separating the left. The left side of the spinal cord is completely fine. There's no damage. So left leg is totally good. What's going to be wrong with the right leg, though? What symptom is this person going to possibly have? Are they going to have a motor or a sensory deficit? And since we're talking about the posterior horn, the dorsal horn and the dorsal columns, that's sensory. So what's going to happen is we're going to have an issue with numbness, tingling sensations in the right leg. Is there going to be any motor deficit? No. The front of the spinal cord is totally fine. So they'll be able to move their leg just fine. The problem is it's going to be numb, tingly, kind of sharp pains potentially. All right. Let's do one more example, and then I'll let you make up your own examples. So we did the lumbar, let's do the cervical region now. So let's do the neck. Same thing, we'll draw our nice cool spinal cord, a little round, but that's okay. It does change in shape a little bit. Okay, and we have our right side of the body and the left side of the body. Now, the spinal cord in this case is not affected. What we did was we injured the nerve leaving the spinal cord. So the nerve comes in like this, and then it eventually combines, right? What we did was we pinched a disc, same thing in our neck, but for some reason it herniated and bulged to where it only affected this nerve right here, this portion of the body. So let's think about this. First things first, is the spinal cord affected? Is there anything wrong with the spinal cord in this picture? So the circle in black is the area of damage. And our answer is no. Actually, I don't even know what the question was. Is the spinal cord affected? Our answer is no. The spinal cord is totally fine. The spinal cord is perfect. There's no damage to the spinal cord. Where the damage is in this nerve that's coming from the ventral horn and the ventral columns. So remember, anything with ventral is going to be motor. So this nerve is the motor nerve. So what symptom is this person going to have? First, is there anything wrong with the left arm or left leg? No, left side is totally fine. Second question, is there going to be anything wrong with the leg, period? And this is kind of tricky, but think about it. The spinal cord is totally fine. The spinal cord is 100% A-OK. So we're not having any of that problems from that injury site down. It's just this specific injury site at this specific nerve. So the legs are fine. What's going to be affected is the right arm. And what's going to be your symptom? Are you going to have motor or sensory deficit? And our answer is going to be motor because it's coming from the front of the spinal cord. So this patient or this person is going to have a hard time moving their right arm. Their right arm is going to be somewhat or permanent or fully paralyzed. They can feel everything. If you stick a fork to them and poke them, or a reflex hammer, or scratch their arm, they feel that. They just can't move their arm due to that nerve being injured. If we flip-flop this scenario, though, if we said this anterior ventral nerve is fine, but we damage the dorsal nerve, the legs are fine, you can move the arm, it's just you would have numbness and tingling in the arm. But if you happen to sever this nerve out here, check this out, one more scenario. What if we damage the nerve here, where we have both motor fibers going out and sensory fibers coming in? Then we're in really big trouble, because then we're having motor and sensory deficits, and it's just like affecting the spinal cord. That arm is going to be possibly paralyzed and numb and tingling. Now the good news is there are multiple nerves that go out to your arm, but you get the point of this exercise. So make sure you're familiar with what happens in a clinical situation. What's going to cause paralysis? What's going to cause numbness and tingling? And if we have a severing, it depends on what part of the spinal cord, right? Quadriplegic, that has to be from the neck down. Paraplegic is basically from the chest or belly down. All right, a lot of information. Make sure you review this stuff. All right, everyone, so at this point, you know everything you need to know for the spinal cord. These next 4 slides are just going to be a quick review, and I'm just going to show you some better pictures. So recall that the gray matter, the groups and bundles and bundles of cell bodies and dendrites, are found on the inside of the spinal cord. It's kind of opposite of the brain. Gray matter was on the outside of the brain, white matter was on the inside, flip-flopped in the cord. Gray matter, all these horns, are on the inside of the spinal cord, and then you can see the white matter, axons, is found on the exterior portion. All this stuff, whoops, white, white, white. All those columns or funiculi. Really good picture here showing you the nerve roots, the ventral and dorsal root. So again, we have our ventral column here with the black star, and those cell bodies are going to send out axons, and the messages are going to go this way to the skeletal muscles. Then we have our pseudo-unipolar neurons from our skin bringing information in to the spinal cord. So that's where we get that 2-lane highway from the nerve, and you can see this is why, once again, your neurons, well, I don't really have a good color for this, do I? Anyway, this area where there's a mixture of red and blue, that is why we can handle or we can detect stimuli and move our limbs at the exact same time, because we have both motor and sensory neurons and fibers going back and forth. So when looking at the dorsal nerve root, we're just looking at the posterior aspect that's branching from the spinal cord and coming toward the spinal cord. And remember that all of those neurons coming from our skin, sending these messages toward the spinal cord, are unipolar or pseudo-unipolar. They help you detect touch in your skin. And essentially what we're doing, if you follow my yellow arrow here, what we're doing is we're just sending the message toward the spinal cord. Now we do hit this little checkpoint, or this little halfway point, where we get this kind of big bubble of cell bodies. And remember, anytime we see a bundle of cell bodies and dendrites in the PNS, we call it a ganglion. So this is known as the DRG, the dorsal root ganglion. And it's just basically a hub for cell bodies. And then we continue sending that message to the dorsal column, the white matter of the spinal cord. And then eventually we're going to send it to the dorsal horn. And the dorsal horn is what's going to send it up the spinal cord to the thalamus. Remember, that's our switchboard operator. And then the thalamus is going to send it to the parietal lobe. Why the parietal lobe? The parietal lobe helps you figure out your touch. It's your somatosensory center, or somatosensory cortex, or area. So that's what's going on with the dorsal. We're going to go to the next slide and cover the ventral, and it's going to be pretty similar. It's going to go in the opposite direction. So looking at the ventral nerve root, this is a motor message. So all motor messages, I lied. Mostly all motor messages have to come from the brain. There are exceptions we'll talk about next chapter. And then that's going to go down the midbrain and the pons and the medulla oblongata, and it's eventually going to arrive here at the ventral horn, where we have all of our cell bodies. Then those cell bodies are going to send axons out to the anterior column, or the anterior funiculus, and then we're going to send the message this way, away from the central nervous system, down to that skeletal muscle to move our hand or our foot or whatever we're moving. So remember, since this is an efferent neuron, these are going to be that very popular multipolar neuron, a lot of dendrites, one axon. And as you can see, the dendrites and the cell bodies are in the gray matter. We called that the ventral horn. And the axons are in the ventral column, and they also come out here to the nerve root. So just a review of everything we've talked about so far.